So good afternoon, everybody. Welcome to the Georgia Department of Public Health Board meeting. We will learn a lot, as we usually do during this meeting, and have time open for discussion. But we can't get started until Mr. Walker takes the roll.
Well, thank you. Dr. Curran,
Here.
Dr. Rodriguez,
Present.
I guess I'm here. Dr. Cheek,
Present.
Dr. Mercer.
Here.
And I don't think we have Dr. White here.
No, the others who aren't here are not going to be able to make it.
Okay. All right. That's who we have present. It's, I yield to you, Dr. Curran.
Okay, do we have any additions or changes from the minutes from the last meeting that we've all received electronically earlier? Do I have a motion for approval?
Motion for approval.
Second.
All in favor?
Aye.
Now we're going to new business. Commissioner Toomey.
Yes, no, thank you so much. And we really appreciate you being here today. One of the things that we did not bank on when we scheduled the meeting was that the legislature would actually be running later this year because of it went longer than it usually does. And therefore, we don't have as much updated information on budget and signed legislation as we would have otherwise. And so that will be put on hold until our next meeting. However, I will say that also is why a number of individuals on the board were not able to come because they're with their families enjoying ski trips in Utah and some other very nice things. And I did want to share with you that Dr. Jane, when he retired from CHOA, was gifted a 1-month training program on how to teach and encourage others to do yoga. And so he's in Boston learning to do yoga and instruct yoga and to encourage others. And I'm probably saying this all wrong, but he told me, and he was so enthusiastic, that I think at a future meeting, we will all be on yoga mats and he will lead the meetings. I thought that was a really neat retirement gift that he got.
So lucky is lucky.
Yeah.
Exactly.
And if you've ever heard Dr. Jane's presentations on being lucky and physician wellness and the importance of understanding, he did have a lucky incident. And he woke up and they said, "What's your name?" And he said, "Lucky." He said, "Yes, sir, you are lucky." But anyway, he does a wonderful physician wellness program, and that's why he's probably was given that gift, because he's been a champion of that ever since he had a special event in his life.
I had no idea, and I'm looking forward to a future meeting to hear. And when he told me, and he's in Boston, he said, "Guess where I'm going?" And I said, "To an ashram. I'll go with you." And he goes, "No, I'm going to Boston to do this." And he was clearly so enthused about it and is looking forward to engaging all of us in the future. I did not know that, and I'm looking forward to more of the story. So thank you.
I'll let him tell the story, but like I said, he's been a champion since that time for physician wellness and for other just wellness in the medical field, as well as
Great.
Work all the time.
Thank you. So the agenda includes some interesting things, not only our EPI update, which is always my personal favorite, Dr. Drenzik, as well as the legislative update that we know about and can at least project to be signed by the governor. But an environmental health update, and I wanted to explain why I thought this was really important to talk about, not only because as a regulatory agency, this whole area garners a great deal of attention, that I have had much feedback about restaurant inspections, but it wasn't until I went on an inspection myself that I realized what was involved in that inspection, that when you go into your restaurant and see posted what that score is, it actually has some significant meaning. And I encourage all of you on the board, if you haven't done so already, to go on a restaurant inspection with one of your local inspectors, and we can arrange that easily, because it's actually a very interesting education. So with that, I'll just turn it over to Dr. Drensick and the epidemiology update.
Thank you. Thanks, Dr. Toomey. Thank you, members of the board. It's a pleasure to be with you this afternoon. So I'm actually going to provide my update about a topic that we have discussed in here before, however, and it's measles, but I want to really highlight the public health emergency that is going on nationally in regards to measles. It's a really very unique and very, very large outbreak. Next slide, please. Just as a background, again, just so that we're all on the same page, I just wanted to talk a little bit about measles. Measles is a viral illness that, again, is characterized primarily by fever, rash, and what they call the 3 C's, which is cough, coryza, and conjunctivitis. And again, the very unique place that measles holds in the world of infectious diseases is that it's really one of the most highly contagious infectious diseases of all. It spreads when a person that is infected coughs or sneezes. It's contagious 4 days before the rash begins, all the way up to 4 days after the rash develops. And interestingly, and this is unique as well, it actually can remain in the air. The virus can remain in the air or on surfaces for up to 2 hours, after a person that's infected has been in an area. So again, that is why measles can spread very, very rapidly. People that are susceptible to measles and who get exposed are actually 90% likely to actually develop measles. So again, we're talking about a very contagious, very communicable illness here. However, despite that, it also is highly preventable. And with appropriate MMR vaccine, 2 doses of vaccine are 97% effective. Next slide, please. So what's going on in the current measles landscape? Again, this is the situation now has changed really over the last decade or so. Although measles was considered to be eliminated from the U.S. in the year 2000, 25 years ago, that really just meant that there wasn't sustained transmission that was ongoing. Who knows how long that will really last, because we're really seeing a lot of changes in the epidemiology of measles now. We're seeing sharp increases both globally and nationally as well. And when we're looking at this year, it's really a very unique year. Just this first quarter of 2025 has had more measles cases, over 600 in fact, than all of last year nationally. And we also have had 3 measles deaths reported this year as well. 2 of them in unvaccinated children, 1 of them in an unvaccinated adult as well. So this unique situation with these huge increase in measles cases is driven by a very large outbreak primarily among an unvaccinated religious community in Western Texas. Began in, really in 1 county in Western Texas. They're now up to 481 cases of measles in Texas, and it has also spilled over to New Mexico, which is, really the eastern part of New Mexico, which is right up against the Texas border. And that's where in New Mexico was where the 3rd death had occurred as well in an adult. And is also spilled over into Kansas as well. So what's going on here? And this is really the kind of very typical, sort of triggering pattern that we see. Measles outbreaks almost always start from an infected international traveler or a traveler that has come, from one area to another. And then because of its communicable nature in populations that are under-vaccinated or unvaccinated, it can just spread like wildfire. So again, the community in Texas in which the measles cases are spreading rapidly are unvaccinated primarily. So again, it can really, once you sort of take a look at how even just a pocket of unvaccinated persons in just a few counties can result in such spread. I'll show this to you as we move along. Next slide, please. So over the last 25 years, when measles was considered eliminated in the US, we really saw very few cases for many, many years, but we've had really 3 big outbreaks, again, over the last 10 years or so. And like I said, all of them fit this same pattern, this same story of an international traveler that then, exposes others. Pockets of under or unimmunized individuals then result in large spread. That first large outbreak that you see, that was in 2014, that occurred at Disneyland in California. You may remember that. New York City, in 2019, had a large measles outbreak among the Orthodox Jewish community, again, who were also, sort of the, unvaccinated. And now this Texas outbreak, where there's, 600 cases or so, the community in Texas is a Mennonite community that is primarily unvaccinated. So let's take a look a little bit deeper. Next slide, please. So if we take a look at measles in the US, it's not only in Texas, although the vast majority, sort of 90% of measles cases across the nation are really occurring in Texas, New Mexico, and Kansas. But we really have cases, that again are scattered in many other states as well. Many of these are not related to the Texas outbreak. Some are, but some are also related to international travel or other travel situations as well. So what I wanted to highlight, really, there's 3 things, and one of them actually isn't listed on the slide. But first of all, take a look at the majority of cases, or again, 40% of the cases, are in school-age children. So again, that's reflective of this population that's under-immunized. Usually we're going to see measles cases in infants that are that are too young to be vaccinated. We usually see it in younger children, but these are school-age kids in this, kind of that drove this outbreak in Texas. Again, 97% of them were unvaccinated, and there have been 3 deaths recorded as well. That's unusual. It's unusual. Measles can be a very, very serious disease, of course, but kind of having 3 deaths. Also, in this Texas outbreak, I think 12 to 15% of the cases were hospitalized, and that's high too. So whether it's just a kind of a reflection of again, other underlying conditions or other, it's really unknown, but I think that it's really can underscore for us that measles is not, again, a mild illness. It can be very, very serious, and it can be fatal. Next slide, please. So let's just take a look at the Texas outbreak in just a little more detail. If you look at the Texas map, the red or the orange box in the western, up the panhandle, right above the panhandle in Texas, that's Gaines County, Texas. That's the epicenter of the outbreak, where most cases have occurred. And the outbreak has expanded now to really that kind of about 10 counties are right around there. Some spread, again, from travelers to other parts of Texas. But again, it's really been very concentrated primarily in this small area of Texas where this Mennonite community is prevalent. I'm showing this epi curve just to show you how intense the spread is. So look at this is like, these are dates, these are like days of rash onset, and these are really, sort of over a period of weeks from January, kind of through now. Look at the intensity of spread. That shows you how fast it can spread over time. Where really, you're not getting a break at all. It's just cases after cases after cases after cases. And they also, there's evidence that these are probably underreported as well, because the community in Texas evidently, has some mistrust of government and healthcare, and so some people may not even be, sort of diagnosed or treated or reported even, but it really just can show you how fast this can spread over time. Next slide, please. So what about here in Georgia? We haven't been spared entirely from measles this year, although it really had nothing to do with Texas. So we have had really, again, not a whole lot of measles outbreaks over the last 15 years or so. We had a large outbreak in 2019. Again, same story. We can think about the same story coming from an international traveler spread in pockets of under and unvaccinated people. This year we had a situation of 3 measles cases in the same family. They were all household members. They all traveled together. They traveled within the United States. It wasn't to Texas. It wasn't the Texas outbreak. This was in January. But again, it also really showed that again, people can pick up measles in a variety of places. International travel is high on the list, but there are many other places here in the U.S. as well, in which there are people from all over the world and can be exposed to measles. So it really underscores again the importance of vaccination. Our family members from this year were also all unvaccinated. Next slide, please. So again, this was just a little more detail about our 3 cases that we had in January of this year. Again, the family lived in Metro Atlanta. They all traveled together, and I really wanted to highlight that whenever we're dealing with a measles case, even a single measles case, much less the hundreds that they're dealing with in Texas, every single one is a public health emergency that requires very intense follow-up and documentation of anybody that could potentially have been exposed, where these individuals were exactly, at what times, what people were nearby. Are there any susceptible individuals, either infants that are too young to be vaccinated, unvaccinated persons for other reasons, pregnant women, anyone that may be susceptible, so that we can offer them prophylaxis, either MMR vaccine or IG if appropriate. And then we really monitor them for the entire incubation period through a period of 21 days, every single contact. And most of these contacts are not susceptible. The vast majority of individuals really are vaccinated. But the ones that are not are really, every single day. We have an electronic system where we go in, make contact with them every day, and make sure that we can track whether they're developing symptoms. So ultimately, we want to stop the spread. So that's the key to measles investigations. And we are proud to say, although it's tricky, sometimes it's a matter of luck, but we are proud to say that our, sort of rapid investigations, we didn't have any secondary cases from this family that occurred here in Georgia in January. Next slide, please. The only other thing I wanted to mention, because we get questions about this, in a situation like this with this Texas outbreak that's so unusual and so intense, sometimes people are wondering, well, is there anything different that we need to do? Do people need to get another measles vaccine dose, for example, even if they're already vaccinated? Well, actually, they don't. For the most part, most individuals are going to be considered immune. Most adults, are going to be considered immune. Anybody who's not vaccinated, of course, it's not different. We want to promote that they do get vaccinated. But there is a situation, like, for example, in the Texas outbreak, where there's this really sustained transmission, where there are some slightly different recommendations in a huge outbreak. And these are the three sort of types of under-vaccinated people that may want to consider getting another dose of vaccine in consultation with their healthcare provider. The first is adults that have only received one dose for whatever reason. And they may want to consider getting an additional dose. Preschool age children between 1 and 4, if they've had that one dose. And again, so the routine vaccination series, of course, is first dose is given at 12 to 15 months, second dose at between 4 and 6 years. So that in between time for kids that are like living right in the outbreak area and they've only had one dose, they may want to consider getting that dose early. And also for infants that are too young to be vaccinated, those from 6 to 11 months, before the 12-month time, it may also be appropriate to consider whether an early dose may benefit them as well, depending on their situation and depending on kind of where they live and what potential for exposure they have. And so that's a little different about an outbreak like this. That's different than kind of the usual that we see with just having some sporadic measles cases, or even kind of like the 3 that we had this year. We wouldn't need to go to this sort of recommendation unless you're really dealing with a big outbreak. Next slide, please. So as I'm concluding, really our take-home messages are ones we've, are common sense and we've heard before, but really the most measles cases and outbreaks are related to international travel, followed by further spread among pockets of under or unvaccinated people. I think that we will continue to be at risk for measles importations and outbreaks, kind of considering the epidemiology of measles now. But if we're thinking about, having like a widespread measles outbreak across the nation, I think that is actually very unlikely. Really, we do have good, for the most part, sort of overarching MMR coverage. Most adults are also considered to be immune. So I think that overall, we shouldn't be facing, sort of Texas in every single state moving forward. But again, these pockets of unvaccinated or undervaccinated people can really drive a concentrated outbreak. MMR vaccine, of course, remains the best protection against measles. And we also just want to highlight, and this has been really a great benefit, if you can think of a benefit of having measles cases, even ours in Georgia, is really having the opportunity to reach out to healthcare providers and remind them that these measles investigations, the sooner the better that we can get on there, so that we can get them isolated, the potential case tested, and we can get involved immediately from the public health side in identifying contacts, offering prophy to prevent infection or to stop spread, as they are so. If you get a rapid response going, right away, and you hear about these things right away from healthcare providers, it makes all the difference in the world in regards to stopping spread. So we continually, next slide, please, have been able to educate our providers, and we have just recently developed this little flyer that really talks about and helps individuals in the healthcare community think about measles, be aware, keep it on their differential, and whether they should test, but to think about isolation, even while you're considering it, isolate, identify the potential for measles, call us, inform. We call it identify, isolate, inform. Call us at Public Health at 1-866-PUB Health. You have a medical epidemiologist on call 24/7 all the time, and we can kind of guide you through that. So we have been actually very thankful that we are getting so many suspect measles calls. It's the right thing. It's not that we want, necessarily, to have measles cases here, but we want to be able to stop the spread of measles. So we want to hear about them. So even as a result of the 3 measles cases that we documented here in Georgia in January, we have had over the last, 3 months or so, probably close to 20 suspect cases that were tested, most out of an abundance of caution or travel somewhere. But again, we haven't had any, they weren't related to the first 3 cases at all. They were it's from raised awareness. So as long as we can hear about these things faster, we can stop them faster as well. So I think that's it for me. And happy to take any questions that you might have. And I think that we can expect that this Texas outbreak will likely go on for months more as well.
Excellent, Sherry. Any comments, Dr. Cheek?
Well, first of all, excellent presentation. I think we might want to mention for the public, though, is that for infants that are 6 months to 12 months, like you talked about, and that maybe would need an additional vaccine, especially since families are traveling more in this world and they're going
Yes.
to places that still have outbreaks of measles, that if they're going to be, especially for any prolonged period of time, or more out in the
Yes.
communities or the places where they could be exposed to measles, that those children, before they actually travel, get that dose of
That early
measles,
dose, yes.
that early dose of measles
Right.
vaccine. That, of course, does not count towards the 2 you still have to have.
Still after, yeah.
Going forward, but would prevent them from bringing measles back
Yeah,
to
that's
their
great.
family and friends and whatever. So something to think about
Very good point.
if you're traveling with a young infant and you can find out places that have potential measles outbreaks in different countries on the CDC website. And I think the Georgia Public Health website links
Yes,
to
right.
that too, that you can, if you're traveling somewhere and you're wondering if does that region or country that I'm going to still have measles that's not in control, or, patient that they have high numbers of measles, then you can look directly there and decide if your child might need an
that's
additional
great.
vaccine if they were traveling.
Thank you. I also heard today, I don't know if it has gone out yet, but I heard that CDC is sending out the CDC has that, they call it COCA network, like clinical.
It's sort of like an alert, but for clinicians in practice, not at CDC and not necessarily in public health.
I heard that CDC is sending a COCA alert today about measles, and it is mentioning that as well. So the changes, the potential to consider for healthcare providers to consider recommending an early dose for either outbreak situation or for international travel. So that's good too. So that's going out, I heard today.
Dr. Mercer?
2 questions. In the group that was the unvaccinated group, has this outbreak impacted their decision to be vaccinated, number 1? And 2, other than death, what have you seen any other significant sequelae?
So I only have heard, reports from like my counterparts in Texas that are dealing with this outbreak. And, we have, and I have heard that this particular community is still quite resistant to cooperation even with the public health investigations at all. So it's very difficult to reach them. You try to find out who might be other people that may have been exposed, or contacting them in general, or contacting them about if there was an exposed person that perhaps needed to be quarantined during the incubation period, that the cooperation level is low. And again, that's not from my direct experience, but what I have heard. So, And other than that, I haven't heard about other serious sequelae. But I think that some of it, ultimately, I think this is all evolving so quickly. I think there really hasn't been a lot of even sort of anything in the literature yet. Even an MMWR hasn't even really been published yet. So for maybe other reasons, but in any case, I think that maybe we'll be hearing more to come. And I'll be sure to keep you updated.
I apologize, but just for pediatricians and other medical physicians that are listening, the Georgia AP is actually sponsoring a measles kind of update webinar, and they're having one of the physicians that has been treating these children from, I think it's Covenant's Children's, Texas Tech University Health Sciences is going to be on the presentation, and that's coming up on the I want to say the 10th of it's a webinar, April the 10th at 12:30 to 1:30. So physicians and
The normal vaccination is what?
might want to listen to that. Just be interesting updates.
Normal vaccination is at
One and four to
One and
six, or
four.
preschool.
1 and 4.
Mr. Walker?
I'd like to ask you a question. First, what's that 800 number?
Oh, this is for providers to call us with suspect cases for any public health type of emergency. It's 1-866 PUB HLTH.
Okay.
And it is not, and again, it's designed for providers to report where they need a consultation from a medical epidemiologist. It's not kind of a public number, but yeah, we've had that in place for many, many years and have used it throughout, really all of our public health emergencies. And we use it even, daily. We have a medical epidemiologist that is on call each day. So.
Okay. There's always been people saying, a comment made that if you've never had measles, you're more susceptible to getting measles, even as an adult. Is there any truth to that, or what do you know about that?
Well, I guess if you've been vaccinated appropriately, if you have had vaccine, and we would hope that would prevent you from getting measles. So yes, you'd be okay. But right, if you were not vaccinated, you would be considered to be susceptible to measles. But individuals that are like adults that are born after 1957 would have thought to have lifelong immunity from having actual infection, as for people that are of that age range as well. So they may not have had this version of MMR, but they had natural infections. So anyone born 57 or
Later.
are considered immune for life. Yes.
I have received a number of questions from the public about, they had read, and I have heard that as well, that there's a small window of individuals who were vaccinated, but perhaps the vaccine itself at that time was not as robust. And I don't know much about it. There was maybe a 10-year period in the 60s.
63 to 69, I think.
Okay.
And then 5% of people who were vaccinated in that window had like the vaccine that was a little less effective. So it's not thought to impact many people as well. And I saw that is actually addressed in this healthcare letter today too. So I'll be sure to cite it.
Perfect. And we can make sure it gets out to everybody.
Okay, that's what I was trying to figure out.
Yes,
No, well, I'm sorry.
it was excellent, Sherry. I did read in the paper, which doesn't mean it's true, but the family where one child died and had 4 other children in the family get measles, the mother still was anti-vaccine. And it gives you an idea. First of all, it may not be true, but it gives you an idea how strong the anti-vax movement is. Extremely, extremely strong. And we all worry that it's going to be facilitated by some of the federal appointees. At least I do.
Anybody in particular?
And then there's two questions I have. One is, what is the microbiologic a way to diagnose measles, number one? And Number two, can you comment on the frequency and severity of adverse reactions to MMR vaccine?
Sure. So measles is diagnosed by PCR, and it can be diagnosed using an oral pharyngeal swab, an NP swab, or urine as well. So PCR is important. A serology is done like as an adjunct along with it, but it's not the primary way. So PCR testing is done, and so when we have for example, if we have a measles suspect, we actually, and we're involved in facilitating testing, it can, as soon as it gets to our Georgia Public Health Lab, they can run the test within 4 hours. So it can be really, it's again, rapid testing that we can then make a decision about investigation right away. And as far as the MMR vaccine, again, it is considered to be a very safe vaccine. And it, kind of broadly with many years of use behind it. So I think that although I'm not an expert on all other adverse events, I will say that this vaccine has been used for many years and is considered extremely safe.
She.
Being a pediatrician and having been giving the vaccine for 40 years, recently retired, I can honestly say, we do have a reporting system for adverse effects related to vaccines. Never have had any of my patients have to use that for really any of the vaccines, but for certainly not measles, mumps, and rubella vaccine. And most recently, we give it now combined with varicella vaccine. But we would tell patients that the side effects are just like any other vaccines. Usually the side effects are mainly a little soreness at the area, something that Tylenol will take care of, and a hot warm. But also 10 days to 2 weeks later with the measles vaccine, you can get a little low-grade fever, usually right around 101, nothing a lot higher than that. And sometimes you do get a little faint rash that may last 24 to 48 hours. But still, in the 40 years of practice, I've got minimal callbacks, even related to the fact, and I just reminded them that to know in a couple of weeks, you might get a little bit of fever and rash, it'll go away, don't worry about it. And that's kind of what generally happened over 40 years of practice. I want to say that doesn't mean I'm an authority. We have to look at many more hundreds of thousands of cases in just one person's experience to actually come up with scientific evidence. And I think that vaccine has been researched for lots of times, not with just my anecdotal experience of 40 years, but with millions across the world. And so considered to be a very safe vaccine.
40 years of kids is a lot of kids.
That's a lot of kids.
Yeah.
Yeah.
I'm not a pediatrician. I've never seen anybody with measles, although I had it when I was younger. But I was chairman of the board of public health at the National Academy of Medicine, and our board and a very famous pediatrician from Harvard, Marie, last name I can't remember, undertook, reviewed hundreds of studies and undertook dozens of studies on the link or the lack of link between autism and vaccines, which is the major concern given the increased diagnosis and expansion of the definition of autism spectrum disorder and the severity of that disorder in the U.S. There's a number of people that continue to link that, but I can say that the studies that were done were extremely carefully done and very clearly disproved any link between autism and MMR vaccine or any other vaccine. And there were some doctors in England in particular who falsely falsified information to publish information on that. They've been rebuked, but it hasn't stopped things. And some of these people in the federal government are going to investigate that again. And they put a very disreputable person in charge of investigating autism and vaccines, which will create no new information that I think of, but that kind of debate makes it harder for people, pediatricians and public health people, to advocate for vaccines because the people that don't want to get shots, that are skeptical of government anyway, are gonna just adds to their skepticism. Well, so-and-so says it causes autism. And autism is a serious problem, but it's not caused by vaccines. But bringing that up again is going to be continuously problematic, I think, in the next couple of years. At least that's how I feel about it. Thanks, Jerry. That's very good.
Dr. Dresnick, let me ask you, is there any concern about an outbreak of these diseases like measles and chickenpox and mumps? I know that, a lot of them, we've kind of had them at bay for a long time, and then it kind of seems like every once in a while, there's a spike or something coming back up. Is there anything that says we may have to be on the lookout for stuff like that now?
Absolutely. So yeah, as we are experiencing in Texas, absolutely. So there are places in the U.S. that have lower vaccination coverage for example, religious beliefs or philosophical beliefs, or really just low vaccine coverage that really can drive these outbreaks. So in general, we wouldn't, like I said, we wouldn't expect necessarily to see like a nationwide huge outbreak because of vaccine coverage. But in these pockets of individuals that are unvaccinated for a variety of reasons, we definitely have seen outbreaks, as we saw here in Texas and in some of the other large ones that I mentioned as well.
Could you identify in Georgia, were these religious, or they were just international people who had relocated, or could you?
Yeah, it was just international.
International that had relocated to Georgia.
Wow.
Yeah, on that same note, I thought you were going to say, when you're talking about the Institute of Medicine, Academy of Medicine, about the global impact that measles has on child deaths, because I think that's something that also is forgotten, that millions of kids have died worldwide of measles. And as long as, and the vaccine has been literally life-saving worldwide. And I think even as we tend to be looking here internally, even just to our state right now.
And the global pandemic of COVID diminished global vaccination rates.
Yes, exactly. For many of the same
Yeah.
reasons, supply chain and also access. But I think it's to bear that in mind, and there'll be more and more opportunity to encounter children who haven't been vaccinated as we have a global travel population.
Well, thank you very much. Mr. Segrist.
Thank you. Well, good afternoon, everybody. My name is Graham Segrist. I've had the chance to meet everybody, I think. I'm going to be giving a very brief overview of some of the direct impact legislation that passed this session. As Dr. Toomey intimated, the session just wrapped up on Friday, so this is kind of late-breaking stuff. A quick caveat with respect to direct impact. We have a fairly narrow approach to what direct impact means in the Office of Government Relations. So this won't encompass the 200 other bills that we tracked this legislative session, probably the most impactful of which being Governor Kemp's tort reform legislation, which we anticipate will have a really positive impact on the healthcare kind of setting in the state and the sustainability of healthcare. Next slide. So the first piece of legislation I talk about is going to be our agency legislation. We worked on this with the governor's office and with our legislative sponsors. You can go ahead and advance the slide. So it's House Bill 89. So this is really a kind of a maternal health cleanup bill that deals with our regional perinatal centers. The first item that it deals with is our maternal mortality review committee, giving them access to psychiatric records. As it stands, they don't have access to these records. And so a lot of the understanding of the mental health of these deceased individuals comes from kind of family testimony or anecdote. So this is going to allow for the MMRC to have a more clinical perspective on the mental health of these deceased individuals. Next, it establishes the regional perinatal Senator Advisory Committee. So this committee is going to be appointed by Dr. Toomey and will be charged with considering and making recommendations to Dr. Toomey concerning the addition, reduction, or transition of regional perinatal centers in the state. So kind of looking at the ecosystem, seeing where we need a new regional perinatal center potentially, or just kind of, regularly looking at the need and adjusting from there and suggesting adjustments to be made. The last piece removes the requirement that a medical examiner's inquiry for pregnant female deaths be done through the regional perinatal centers. This was put into law a few years back, and I want to clarify and make very clear that the requirement that these medical examiner inquiries is done is not changing. That will still be done. It will just not be done through the regional perinatal centers. They just don't have the capacity right now, and so that'll be handled through the medical examiner's office. So that's all that House Bill 89 does. You can go to the next slide. And so now these are not pieces of agency legislation. These are just direct impact legislation. Next slide. So House Bill 567 deals with teledentistry. So it authorizes and regulates teledentistry here in the state. The reason this is direct impact is because DPH does actually offer some teledentistry services throughout the state. And because this legislation adds some extra regulations around teledentistry, that would have impacted us. Fortunately for us, the sponsor and the advocates are working on this. We're willing to carve us out to allow for us to continue to do our work without needing to kind of fall within this legislation. It also allows for coverage of dental services done through teledentistry. Next slide. House Bill 398 is a bill dealing with cottage foods. As it stands right now, the sale of cottage foods, which are kind of shelf stable, fairly safe. It's like things like maybe your jams, your jellies. I'm sure Galen has a list that keeps him up at night of different cottage foods. As it stands right now, they are you're able to sell directly from the producer to the consumer. This bill will allow it to be sold through a third party. So whether that be a store, the reason we're involved is that it does allow for these to be sold in a restaurant. You can think of like a restaurant gift shop, or maybe at the front hostess table or whatever. So that's how that impacts us. Next slide. So Senate Bill 46 is the Government Service Renewal Act. So this seeks to improve government service delivery in the state of Georgia. The Georgia Technology Authority is going to appoint a state of Georgia government service delivery lead. And that individual is going to be responsible for coordinating with all the agency heads to improve the delivery of service within the agency. So there's a kind of a litany of different requirements and things that this individual will do, but we'll certainly be nimble and looking forward to working with that once that individual is appointed. Next slide. Senate Bill 58. This is the Georgia Transporting Life-Saving Organs and Personnel Act. So this is going to provide for the licensing and operation of emergency organ transport vehicles as ambulance services. So within the Office of Emergency Medical Services, this will be a new type of license. There are some kind of carve-outs associated with that. These won't need medical directors. So it's kind of a pared back version of an ambulance and how we traditionally license them, but it will still fall under DPH and OEMS. Next slide. Senate Bill 96. This one is it's a cleanup bill. These happen most sessions. They just remove old boards and commissions. For us, these are the Georgia Council on Lupus Education and Awareness and the Georgia Palliative Care and Quality of Life Advisory Council. Both of those are pass-through entities for us. The funding just comes through us. Those are being repealed. So it won't have a direct impact on the work that we do, but it does impact our finance department. Next slide. Senate Bill 100 is Andy's law. So this is going to provide for the issuance of a copy of the original birth certificate to adults who were adopted. So if an individual who is 18 years of age or older has been issued a new birth certificate, this will allow them to receive a copy of their original birth certificate. It also requires that they only pay the uniform fee for that birth certificate. Next slide. And now we're to the resolutions. House Resolution 847 will create the House Study Committee on Evaluating Funding for Public Health. Really, the purpose of this committee is to study how our public health system works, how it's structured and funded, what services are delivered, and then kind of contemplates if further state funding is necessitated. This is a very friendly resolution, and we're looking forward to working with the sponsor and the chair on this legislation, or on this resolution rather. Next slide. House Resolution 72 is the House Study Committee on Cancer Care Access. So this is just going to create a study committee to evaluate and make recommendations for the improved access to quality cancer care in Georgia. The reason that this is impacting us is because of DPH's Cancer State Aid program. So we anticipate that we'll maybe get the chance to share a little bit about that through this process. I don't know that I put a question slide. Frederick will advance. Oh, the best. Thanks, Frederick. What a guy. So I'm happy to take any questions that you guys have.
Kathleen, do you have any comments?
No, I think that we have been following this very, very closely and I said, we stay in our lane, but that doesn't mean we don't pay attention to everything going out that will affect the other agencies and particularly the other health agencies. And I think as we see what actually emerges with the governor's pen, we'll have more to discuss at the next meeting. But, and just getting back to that public health bill, I think that goes back to some conversations we had with the chair of House Appropriations and the subcommittee on health appropriations about, what does public health need to do the work we're doing, and particularly in line of some of the changes going on in federal as well as state government. And I think that'll give us an opportunity to articulate some of those changes as things become more clear, because right now, nothing is clear until something is written. But we'll stay on top of this.
Any other comments or questions for Mr. Segrist?
I would like to ask you a question. Could you expound a little bit more on the cottage bill? I know that it's like from the producer, I guess, or the farmer, whereas now you see the farmers at the roadside stands and stuff. So now you're saying the third party, meaning they can sell directly to restaurants themselves, or?
Yeah. So my understanding really is that they would be able to utilize a restaurant or a store to sell their product. So whether or not they sell it to the, to the store and then it's sold from there is unclear. Maybe I'll take a better look at the legislation, but kind of a copy.
This is really fascinating. For whatever reason, don't ask me what, Mr. Walker, I became obsessed with having apple butter and Georgia peach jam. And I bought it from Etsy, but from Georgia Farms. But this was before this bill passed. I wonder if this was illegal. This was hot apple butter. I don't know.
It wasn't illegal.
It wasn't illegal. Etsy can do anything they want.
Well, no, so so the cottage food, the way it currently is before this passed was the licensee could only sell directly to an end consumer themselves.
Okay.
And so this, like what Graham was saying, is that will allow them now to go into grocery stores, and the grocery stores can sell the product, or a restaurant can put it on display in their lobby or whatever, and then sell it that way. But they're not going to be able to sell to the restaurants for the restaurants to use as ingredients.
Yeah.
No.
Oh,
Okay, that's what I was
I
wondering.
get
Right,
it.
yeah.
I get it.
Okay,
No, I was
yeah, you got
I
exactly
see.
the my point.
Yes,
Yeah.
yes.
No, I was taken aback by the cottage industry. As a cottage cheese, is it what? I had never heard that term, and I realized.
Definitely not cottage cheese.
But I am very much I really enjoy local cottage industries here, the food that they produce, so.
So Graham, that was a very succinct and clear presentation of a lot of work that was
Yeah,
done.
like-
So congratulations,
yeah.
thanks.
Yeah.
Mr. Baxter.
Good afternoon, everyone. My name is Caleb Baxter, and mine is probably going to be even more brief than Graham's, but I just want to kind of give you an overview of the food service program and sort of what environmental health does with the involvement of that. The primary mission, next slide, please. Sorry, I forgot what we're doing there too. The primary mission for the food service program is to minimize foodborne illnesses. And we do this through the regulation and inspections of over 42,000 food service establishments throughout the state. Foodborne illnesses complaints are investigated and actions taken when any risk factor violations are identified. And the local environmental health staff provide education and training to the food service employees and the managers and general public as well. All right, next slide. So we do share food safety responsibilities with our sister agency, the Georgia Department of Agriculture. DPH regulates food service establishments such as your restaurants, caterers, mobile food operations, excuse me, temporary food service operations, ghost kitchens, incubator kitchens, breweries, wineries, and distilleries that do not distribute their product off of their property. And the Georgia Department of Agriculture is responsible for regulating the food sales establishments such as your grocery stores and convenience stores. And they also have the cottage food operations. All of those are fall under their retail food safety program. And the Georgia Department of Agriculture also regulates manufacturers and breweries, wineries and distilleries that do distribute their product offsite. And so sometimes we can actually be dually regulating one of these facilities
At the same time.
if they have a food service operation inside of it, but they're also manufacturing their product and distributing offsite. So that makes it interesting, and which brings me to the next point that whenever we do encounter these sort of odd, unclear operations, we have a memorandum of agreement with the Georgia Department of Agriculture that we use to help us determine, who has regulatory authority or if we have to split the regulatory oversight. All right, next slide. So to give you an idea of the growth rate of the food service industry over the last 4 years, you can see here that it's increased a little bit over 18%. So next slide. When you compare that to the smaller growth rates of the environmental health specialists over that same time period, you can see that the workload has increased significantly. Next slide. So environmental health specialists, they don't just inspect restaurants. They're also responsible for regulating the other businesses as well, such as public swimming pools, tourist accommodations, body art establishments, and septic installations. They have to have a strong understanding of science, so that requires at least a bachelor's degree with 27 hours of laboratory science. They also undergo an on-the-job training program for up to 2 years sometimes, and they're required to be certified in on-site installations, pool operations, and food safety operations. They provide education to the public and to the facilities that they regulate. And part of their job is also to assist any of the new businesses that are opening or any changes of ownership with, conducting the plan reviews and staying in constant communication with the applicants to help them through the process. And then finally, when necessary, obviously, there's always the enforcement aspect of it if, public health is being threatened for any reason. All right, next slide. So the cool thing about Georgia is that all 159 counties follow the same set of rules and regulations. And that's an oddity because when you look across the nation, most states are split up into different jurisdictions. And so that kind of throws people for a loop when they come here to Georgia to try to open up, an an odd sort of food operation, which I have some photos and I'll describe in just a minute of what we do have here in the state. But the cool thing is Georgia is one of 5 states that have adopted the most recent food code. The only other ones are Colorado, Connecticut, Missouri, and Pennsylvania. All right, next slide. All right, so here we go with some innovative food operations that we have here in Georgia. Georgia and Las Vegas are the only 2 places right now in the U.S. that have this robotic arm for as a robotic bartender. And there's a couple of other a couple of other facilities here in the state that have revolving sushi belts. So if you sit down at your table, put in your order, and there's a little belt that comes by your table that has the food that you can pull off and put it down. And then we've had to include sections in our food rule in the last couple of years to accommodate all the movies that were going on. So we had to add a special section for movie catering and a concept called a pop-up food service, which is where if you're working downtown in a building and you don't have any restaurants close by, restaurants will come and set up in the lobby of that building, and you could have different restaurants in there every day. So it kind of helps people who are stuck in areas that don't have restaurants close by. And there was that Volcanic Rock Steakhouse opened up a couple of years ago in Forsyth County, where they start cooking the steak in the kitchen on a volcanic rock, and they bring it out and it finishes cooking in front of you while you eat. So the faster you eat, the more rare the steak is, or you can sit it there and let it cook for a while. So, we had to work with them because of the type of materials that they were trying to use for this. We had to make sure that volcanic rock was, cleanable, that it wasn't going to make anybody sick. So that was interesting. And then finally, ghost kitchens, incubator kitchens. We have nitrogen-induced drinks that when you drink it, it gives you what they call dragon's breath because it's so cold, the steam comes out of your mouth. Your daughter had one of those. Yeah. And then, cat cafes, so people can go in and we don't let the cats get on the table of the restaurant, but you order your food in one area and then you can take it to a different area and in to-go packages or whatever, and then you can sit and eat with the cats, but they're not allowed in the kitchen, so.
Well, that's a good thing that they don't allow them
That's right.
to do that.
But it would be like if you go to the park with your dog,
Okay.
you get your food to go and you go sit outside and, it's the same thing. It's just you go sit in a room with cats.
I was at a restaurant one time and this lady had a little bitty dog, and how they have those tables like this where everybody's sitting there. I may not know you, but we're at the same table. She put a dog up on the table, and she was sitting right next to me and had a little vest on and thought I was supposed to be happy about
I
it.
know.
And it's just walking around the table. I'm like, are you serious?
Call the health department. Something happens.
Goodness gracious, that's so
Because
funny.
that's not.
But one of the most significant pieces of public health legislation you will facilitate was dogs on patio.
Yes, and so a few years ago, there was a bill that was introduced to allow folks to, because right now you can already take your dog on the patio and eat. That's no problem for you to eat, and your dog is with you. But we're trying to make it so that you could feed your dog on the patio, and we were not really thrilled with that because of the whole, propensity for biting in that case, and dog fights and other things. But it didn't pass, so we were okay with that.
Again,
Any
the
other
question
questions? Yes.
regarding I'm sure there's a cost to these inspections.
Yes.
So who bears the cost of this inspection? Because if it continues to grow, is it the state or are the businesses responsible for paying to get inspected?
So each Board of Health sets the fees for the
Okay.
cost of the service,
Okay.
and that is borne by the actual restaurant.
So, and if they get a bad review, when you come back to look at them again, are they paying again or is that part of that one-time fee?
That depends. So there's typically, they get 2 inspections a year,
Okay.
unless, they make consistent A's, then it can drop down to once a year. But depending on what the Board of Health has set for the fee, Some will charge for re-inspections and some do not. But yeah, it just depends.
And are you able to close down a restaurant if the inspections are consistently?
Yes.
How long does it take for that process to occur? In other words, is it one inspection twice a year and it takes 3 years after 6 inspections, or?
No, so it depends. If we go in there and there's sewage all over the
Yeah.
floor, that's immediate closure. You close down until you get that fixed. If it's just a particular violation that they keep getting the same
Sure.
repeat violation over and over, then after the third one, then we can close them.
Gotcha.
So, yes, ma'am. Do you have?
When you're talking about cottage industries, would eggs be considered a cottage industry? Because more and more people are selling their chickens eggs. I go to, markets or, some farmers markets or Saturday markets in the square or whatever, and I'm seeing more and more eggs available for sale. Is that considered a cottage industry? And also, answer that first, and I have one more question about eggs.
So under the cottage food rule or the cottage food law, eggs don't fall under that particular license. So if you're going to sell eggs to the public, I believe Department of Ag makes you get a totally separate license for that.
Really?
Yes,
I don't
to
think
sell
people are
eggs.
doing that.
I don't think people
But
would do
you
it.
may need to check. That's what I'm saying. You would have to check from there.
Well, so I think that might be an opportunity for the Department of Public Health to educate the public on that, because I think for me as a consumer, I don't have chickens, but I live in an area where lots of people have chickens, and people are always giving me these eggs, and they tell me, don't wash them, do wash them, leave them out, set them out. It's okay for 2 weeks. So, I, as a consumer, I don't think have a good understanding of these eggs that I'm getting, what is the best way to handle them. And I was recently traveling in Italy, and I go in a regular supermarket, and there's whole stacks of eggs sitting out that have never been refrigerated. So I think the situation is if they're never refrigerated, they can stay out for a longer period of time but once you put them in the refrigerator, they're supposed to be refrigerated. But anyway, I'm not giving that out as public information. I think you need to educate our public on fresh eggs, and then, the
Who can sell them?
who can sell them, who can't sell them. And then just if you do choose to buy eggs at the farmer's market, how should I handle them? Because I don't really, I didn't grow up with that. And so I think there's enough of us consumers out there that you could help educate us on that.
Kaylin, is that something you would do in partnership with Department of Agriculture? Because I don't think you could do that by yourself.
Right, that's correct. Yeah,
Right,
so I can check with them and see. if
They maybe already have it, and I'm just ignorant and don't.
Because I would think in these formal farmers market, like you have at the Carter Center and Morningside, I would think that the folks selling the eggs kind of are
They're much smaller ones than that really, you just see people,
roadside stands. even.
they're right next to the service station, and they may be selling, whatever else, their jams and jellies, and somebody just brought 4 dozen eggs and have them sitting there, and they're selling them. It is what it is. Am I the only person that's ever
No,
No.
that's.
not experienced that?
No, I see it all the time.
And especially with the price of eggs right now.
Sure.
And it's become much more popular for you to have them in your yard, or even in communities. And I just think a little more education for the general public, for me, general public, I could use it.
Again, is there any works in place to keep up with the number of inspectors that are required for the growth of restaurants? I mean, how do you mitigate that? Because essentially, if it continues to grow, and since you're being paid for that service, it seems like it makes sense that you should be able to develop a plan to start projecting what your future needs are going to be.
Right, and so actually, we are in the process right now of conducting a time study
Okay.
for the amount of time it takes for services.
Sure.
Because, not just restaurants.
It's a 2-year training program, so
Right.
it's not like you could say, okay, tomorrow we need 4 more. You have
Right.
to start anticipating this with advance.
Yes, and so we're hoping to have those numbers together to send out to the districts.
Okay.
So that, we can talk with the district health directors and let them know we need some more staff, to accommodate the growth that's going on in the state. So, yes.
Kaylin, I think it'd be helpful for them to hear a place like Fulton or DeKalb
Yes.
or Gwinnett, how many restaurants they have, because it's really surprising what the numbers are, and are continue to grow in those areas. Where are they developing? Or in the 13 county districts, you know, that you have these smaller number, but spread out over this huge area. I'll let you give the numbers.
Well, off the top of my head, I don't know. So for example, Fulton, you know, the last I checked, it was almost 5,000
That's
restaurants
what I remember
that
too.
were in Fulton, but it may be a little more than that now because of the rapid growth. But now you add on to that the body arts, the tourists, all of that. Those are just exploding. And believe it or not, Fulton actually has a pretty active septic program. So in the northern part, it's building. So there's a lot of septic development there and in South Fulton as well.
So does inspection come from the state and not from the local, and you oversee? It comes from the state.
So we develop the rules and regulations, and then the local boards of health employees, the environmentalists, they're the ones who do the
The local
inspections.
ones, okay.
Yes.
Let me ask you a question, please. Excuse me. When a new restaurant comes to town, like you had some examples up there, the robotic arm to
Yeah.
pour drinks and the volcanic steakhouse and stuff. When new restaurants come with those,
Innovations.
yes, I want to say something else, but anyway, those type of ideas, how do you develop your standards or criteria in order for them to be permitted? Because they don't seem like to be the regular run-of-the-mill type restaurants that you would have a program. Do you have to then do a special program for them or stuff? Or-
So not necessarily a special program. What typically happens is the local environmentalists, when they see those come in, panic and they call the state office. So my food program director is the one who will sit and help work, you know, help them evaluate. And a lot of times the stuff will actually come to the state office where they will review it and they use the criteria either from the FDA or from NSF. So there is a set of standards that things are compared against because they still have to be smooth, easily cleanable,
yeah.
you know, the basics.
Right,
And if we can't find that based on what we're looking at, a lot of times we've had to reach out to the manufacturer and have them provide something to us. And if it hasn't been, you know, NSF approved, or if it doesn't have an ANSI standard, then we have to get the manufacturer to give us something that verifies that it does meet this criteria that we have. So we have had a couple of situations. The volcanic rock was one that we had to deal with. But then a few years ago, there was an ice cream machine that came from Italy that was interesting, trying to read the, you know, manual for that in another language. So we had to work with them to get them to provide us the information that we needed so that we could review it. But yeah, it's a process.
yes, I can imagine.
Does volcanic rock hold heat longer?
Yes.
Except the park?
Yes.
You know, what's kind of concerning about what you just said there is you may have to coordinate with the federal Department of Health.
Yes.
And then I'm thinking about what Elon is doing and stuff and just, you know, wreaking havoc there. You could get in a situation where you need to draw on that resource and nobody's home.
That's true. Yes.
And I know when we've had big sporting events and soccer things, nationals coming, how do you ramp up? Because sometimes the food industry maybe doubles or triples during those periods of
Super Bowl.
time. How do you ramp up for those kind of events?
So when the Super Bowl came, Fulton County had the lead for that. But we, at the state office, we actually had to help step in because I don't know if you remember, but the FDA, the federal government shut down. So our federal partners were not available. So it came to us. And so we worked closely with them, and it took a while to coordinate all that. They started, you know, months in advance, and there were lots of lessons learned through that process. But also reaching out to some of the other districts, asking for assistance to see if, you know, and we had several EHS come from other counties to come up and spend a couple of weeks here that it took to get everything, you know, ready. So it was a lot of fun in one aspect.
Except
And
for
not
the
the other.
credentialing. We
Except the
won't go there.
credentialing.
Yeah, we won't go
So
there.
that was a whole different thing.
These opportunities come up, these large events. we usually get a lot of local, smaller county staff that want to volunteer because they'll never have that opportunity in their community. And so it's usually not hard to find volunteers.
Galen, you can tell there's a lot of personal and professional interest in what you do. Thanks for the,
Very fun. Could I also make one comment that you haven't explicitly said, but I will? And also in Dr. Drenzik's shop, the collaborations we have across other agencies go way beyond just Composite Board and the health agencies. With Department of Ag, we're working closely on bird flu, obviously on the food services. We meet on a regular basis, talk on a regular basis. And I think that's one of the real values we have. We quietly are behind the scenes working, low THC, hemp products, other things coming down the pike. And this is something that the public may not be fully aware of, but we're trying to make, we may be separate state agencies, but it should be seamless how these activities work together in partnership with us.
I mean, it's really a great tribute, the bad reputation that those of us who used to work in government or people do work in government do is that people are trying to avoid work. And what you actually have is people competing to help each other to get involved and to make sure things are done right and having memorandum of understanding of how they work together. So congratulations. That's really terrific. Thank you.
I really, again, offer the opportunity to go on a food inspection in here, because it was an eye opener. And the first thing I do when I walk in a restaurant is I look at the inspection. I go, woo, it doesn't stop me, but I'll look again the next time I go.
Or you go on a brew pub tour.
What's that?
You go on a brew pub tour.
Oh, my goodness.
Well, thanks a lot. Does anybody have any comments or questions about anything else in the world,
In the world. No.
particularly Georgia?
Are you- probably not.
I guess, do we have a motion for adjournment?
So move.
Second.
All in favor?
Aye.
Thanks a lot for a great meeting.
Thank you. Appreciate it.
Get on the road.